Welcome to The Lens, hosted by Catalysis, where we get a glimpse inside healthcare organizations that are transforming to a culture of improvement to deliver continually higher value outcomes for patients, staff, and communities. Visit createvalue.org/The Lens for more information about Catalysis.
Thank you for tuning into The Lens. I'm your host, Peter Mariahazi. Today, I am thrilled to be joined by Steve Shortell, Dean Emeritus and Professor of the Graduate School at the School of Public Health and the Haas School of Business at the University of California in Berkeley. Steve also co-leads the Center for Healthcare and Organizational Innovation Research and the Center for Lean Engagement and Research. Steve is here to share with us the latest research on improvement efforts in healthcare and, very importantly, the connections to measures of quality. We are also deeply appreciative that Steve also serves as a member of the Catalysis Board of Directors. Hi, Steve. Thank you for joining us today.
Good to be with you, Peter.
Steve, can you just take a moment and beyond what I've said, introduce yourself to the listeners and just so they get an idea of what your days are like?
Sure. Well, I'm very active here at Berkeley to the extent we all are on Zoom now, of course. Have a very active research portfolio, and a lot of it has been around the correlates, determinants of quality of care. And throughout my career, it's been an area of research of great interest to me, particularly looking at the organizational characteristics and processes that promote quality of care. And we've been delighted to have the support of Catalysis and others for our research center because we're trying to shed some evidence that's going to be useful to the field in terms of really eliminating the waste that we have in this country in delivering healthcare. And that's been highlighted, I think, by COVID-19 and the ability to respond to that quickly. So I look forward to our questions and discussion.
Yep, I'm very excited as well, Steve. A couple of years ago, the Research Center, CLEAR, conducted significant research of healthcare organizations in the U.S. To get our listeners caught up, can you give us a high-level summary of those findings?
Yes, back in 2017, we worked with the American Hospital Association on doing a national survey of the lean management system, organizational excellence in the nation's hospitals. And we have data, Peter, on over 1,200 hospitals. And we found out at that point in time that about 69% reported doing some aspect of lean. And it was actually 61% when we sort of correct for non-response bias in the survey. So you have roughly 60% of the nation's hospitals reporting doing something around lean. However, only about 12% of those were what we would call mature. And we measured that a number of different ways, number of years doing it, number of operating units doing it, even self-reported. And so the depth of the implementation isn't there in many of the nation's hospitals. So what we did, though, we were able to analyze those hospitals reported doing lean with a lot of at least self-reported performance measures. And we did find out, as you would imagine, that those doing lean and doing more of it in terms of implementation had greater self-reported performance. But that was just self-report. And so what we then went on to do, that paper, by the way, is in the Joint Commission Journal on Patient Safety and Quality. What we then went on to do is to look at some independent measures, objective measures of hospital performance organization-wide. And these included the publicly available measures such as inpatient adjusted expense per discharge, the Medicare spending adjusted as well, standardized mortality across many of the operation procedures. We also looked at the HCAHPS scores and things of that sort. We looked at profit margins and so on. And what we found there was we were only able to look, Peter, at the adoption at that point in time because our measures were in 2017 and we didn't have performance data independently in 2017 or 18. So we had to wait for that. I'll talk about that in a minute. But we found relatively little relationship between merely lean adoption and these other measures. We did find, however, interestingly, that those hospitals doing lean had lower Medicare spending per beneficiary than other hospitals in the United States. And that was significant. So that was our work back a couple of years ago.
Well, thank you, Stephen. And you've got some exciting papers in for review. In fact, I think one of them is with the Joint Commission. Tell us what's going on with those papers and kind of where they're at in the status of review.
Yeah, it is exciting. And this is our updated research. We've been able in the past year to get 2018 performance data. So we can now analyze what hospitals were doing in 2017 and actually implementing lean. And the association, at least, maybe it's not totally causal, but with 2018 performance data a year later. And what we have found in the paper under review at the Joint Commission now is some more robust relationships with some of these performance measures. So we looked at the number of operating units, up to 29 operating units in hospitals that are actually doing lean. And we correlated those, Peter, so that we had a valid measure with separate measures we had of leadership commitment, of daily management system use, of the training index, and so forth. And they correlated well. And so the number of operating units is our measure of implementation. And the greater the degree to which hospitals are really implementing lean, we found statistically significant lower adjusted inpatient expense per admission, lower adjusted unplanned 30-day readmissions, above the national average in making safe use of imaging. In other words, better use or less use of low value care and more use of appropriate imaging. And we also found significant relationships with the patient experience scores as well. We did not find relationships with mortality per se, Medicare spending, or indeed profit margins as such. But there were still these encouraging relationships with some of these other kinds of measures. So that paper is under a revise and resubmit. We've improved it, I think, with good feedback from reviewers, and hopefully that'll be out sometime in the coming year. And then, Peter, I have a doctoral student here at Berkeley that what we were able to do, our center is part of a national center partnered with the Dartmouth Institute, Harvard, and the High Value Healthcare Collaborative. And that initiative collected data on hundreds of hospitals around the country as part of an ARC-funded comparative hospital performance initiative. And what we were able to do is we were able to overlap or match our national survey with this other survey, and we found 223 common hospitals that reported to both. And that enabled us to then look at our measures of implementation, years doing it and so on, with these fine-grained process measures of quality of care. And what we found is very interesting, and I'll talk a little bit about them. Namely, we found that the hospitals doing lean, or put it this way, the greater the number of years they were doing lean, we found positive associations with greater electronic health record decision support. They were doing more of that than hospitals doing very little lean. They had greater quality information management participation. They made greater use of evidence-based guidelines, and they made greater use of support for care transitions. And in order to build that out a little bit, I'll give you some idea, and the listeners, of what we're talking about in terms of those behaviors. The evidence-based guidelines were written down and approved for congestive heart failure, acute coronary syndrome, hip fracture, community-acquired pneumonia, sepsis, preeclampsia, neutropenic fever, inpatient radiology, and serious mental illness. And when you looked at the EHR decision support, we asked if those tools were used for some of the same conditions I just mentioned as well. And then when you look at whether or not, for example, the relationship with quality-focused information management, we asked them whether or not they used that information and collected it only, or did they really use it for internal quality improvement? And we asked that for preventive services, patient experience, overuse of medical tests. Did they feed that back to their physicians and staff? Underuse of medical tests, acute coronary care services, clinical quality measures, and cost of care. And then finally, on the care transitions, where we found hospitals doing more lean did better with transitioning care. We found that in terms of reducing the risk of readmission, if they did medication reconciliation, telephone follow-up within 72 hours of discharge, in-home follow-up, 72 hours of discharge, standardized processes were in place to follow up with primary care or specialty care. Discharge summaries were transmitted to the clinicians that accepted the care of the patient after they were discharged from the hospital. Did they use a patient navigator or care manager while the patient was in the hospital? And did they use a care manager or a health coach post-discharge? So the bottom line is hospitals really implementing lean did significantly better on all of those kinds of metrics than those not doing lean. So that is new information. That paper has been accepted in a journal called Quality Management in Healthcare, and we think that'll come out also sometime in 2021.
That's great news. And you know, Steve, that really ties to our previous podcast with Dr. John Toussaint, talked about efficiencies in healthcare and being able to change the payment model so that the incentives are more driven towards quality and patient care. And what's interesting is you were reading some of those specific items. To me, thinking of it as somebody outside, if you will, the industry, and as a patient, you're caring more for me. You're providing me the services to make the healthcare process much more comfortable and gratifying. So it sounds like it's all tying together, and you've done a great job of collecting the data to support that and show that it works.
Yeah, and just tying into what you mentioned about John, we really, as you know, Peter, and probably many of the listeners, we need to move to health budgets in this country. We need to get rid of the fee-for-service and create risk-adjusted so that hospitals and everybody have the incentive to innovate, to really implement lean, where you are going to earn the savings. You keep people well, keep them out of the bed, or get them discharged sooner safely to the aftercare and so on, and engage more in prevention. That's going to be so important going forward. John and I and others are developing something we call the Better Care Plan, which is designed to pay providers differently. And I think once that kicks in, to the extent it does, you're going to see lean and organizational excellence, I think, mushroom around the country. And that still needs to be seen, but I think things are headed in that direction.
And as you said earlier, it's all about removing waste and improving outcomes for the patient and for the system as a whole. And secondarily, and probably just as importantly, the caregivers themselves. And as we go through this time with COVID, it is absolutely critical that we're taking care of the whole system. Otherwise, we just don't have the capacity to keep up, and we run into some challenges.
Yeah, absolutely. Just on that point, Peter, about the things that are going to promote this, it does take time. Our data suggests that, and of course, the work of Catalysis and others with folks indicates that as well. There's a recent article your listeners may be interested in that came out in the Journal of Healthcare Management, not ours, some colleagues, that followed Indiana University Health System. And they are one of our research collaborators at CLEAR as well. And they looked at 5 years of rapid improvement events, 5 years. And what they found was that in 45% of those events, they documented some benefit. Most of it was in cost reduction. First, and then later on, it was really in more time savings. Cost reductions can be the low-hanging fruit, and later on, they found it was saving time, and particularly in the emergency department, which is a good area to start a model cell in. So that's some evidence that this does take time, but you begin to get some benefit. But you can look at it, the glass half full, half empty. It's half full. 45%, but 55% of the time, no benefit yet. So you have to keep working at it.
Yep.
And what we have found, we're now doing a study of the daily management system with Indiana University and others in our research collaborative. And what we have found, several things about that's going to promote this, we think. One is that alignment with True North, with the strategic priorities of the organization and on down to the front line. Ongoing leadership commitment from the board on down is key. Really installing the continuous improvement culture every day. It's never ending. And then the training that goes with it as well. So I think those are the things that we're going to see kick in as this continues to move forward.
Thank you, Steve. That's a great way to close it as we talk about the importance of everybody being behind the strategy and the motion within the healthcare system to be able to improve outcomes. So, Steve, do you have any final thoughts to share with the listeners real quick?
I think my final thought, Peter, would be the COVID recovery that has to take place now, and the use of the ways of managing and leading our hospitals and our physician practices differently. Those that have implemented more of the lean principles, the underlying Shingo principles, I think are going to recover sooner. They're going to learn faster as well about what really needs to be changed. They're going to develop new care models faster, hospital at home and related models. They're going to be thinking of creative uses of telehealth expansion and extension, particularly in rural areas, as we get more broadband built out there as well. And so I think those would be my thoughts, is to continue to study this as the nation's healthcare system begins to really eliminate waste big time and reorient totally new ways we need to deliver care from the lessons of COVID-19. And that goes with paying for it as well. Those who earned their money up front did a lot better because they were free to move resources around. They had earned their revenue by the patients enrolled per capita, et cetera, versus those who suffered from fee for service and are really behind the eight ball.
Steve, great way to close that out. Thank you so much for joining us today.
You're welcome, Peter. Thank you.
All of you, thank you for listening. When the papers that Steve has submitted for publication are ready, you will be able to find them at the Catalysis website at createvalue.org. You will also find other resources that can help you lead in the consistently changing healthcare environment. All of us at Catalysis hope you stay healthy. And as always, thank those working on the front line to keep us all healthy. Stay tuned for more episodes designed to help healthcare leaders support their organizations on a journey to organizational excellence.
Thank you for listening. Visit createvalue.org/thelens to learn more about how Catalysis can inspire you to accelerate change in your organization.